Thank you so much, and it's a great honour and pleasure to be here speaking to you this morning about the role of general practice in deprivation health. This is an issue that I feel very passionate about, and it's a great pleasure to be a part of today. So, as Victor said, I'm just going to make sure that I can doof these forward. Is it the green button to go forward? I am a GP partner in a practice called Craig Miller Medical Group, which is one of Edinburgh's deep end practices. But before that, I worked in the homeless practice in Edinburgh called Edinburgh Access Practice, and I worked there for 5 years, which has also given me quite an interesting perspective in what it's like to transition from a specialist healthcare provision to a more generalist healthcare provision, and how that feels as a practitioner, and also how it feels for our patients, because it's not always as easy as it should be, and I'd like it to be better. So I'm going to touch on that as well today as we go through. You'll probably all have heard of the Deep End, I imagine, yesterday, but the Deep End group of practices in Scotland are the 100 practices in Scotland serving the most deprived communities in terms of who we care for. And it's a really fantastic group to be a part of, I have to say, in terms of the peer support that it offers and the research that it does and the projects that it runs and the influence that it has increasingly on making policy in Scotland. So it's a great joy to be a part of the Deep End and call myself a Deep End GP. I thought it would be useful just to think about what does it mean on a day-to-day basis working as a GP in the deep end. And of course, much of what we do as GPs is pretty core across all practices. But there are very specific features, I think, when you're working in an area of higher deprivation that you tend to see and experience more of. We tend to see that even simple things tend to be infused more with social complexity behind them, which makes it harder to be able to give the straightforward advice and follow guidelines in the way that maybe you can in a more affluent community if you're working there. And we also tend to see that people develop the diseases of old age much younger than they would do if they were living in more affluent areas. So we see people developing lung disease and heart disease and many other chronic diseases 10 to 15 years earlier than you would in the more affluent areas. And that has a huge impact on the workload of deprived practices. We also are much more likely to see people who are presenting with mental health issues or addictions issues, and we also have a higher cancer prevalence in terms of more people developing cancer, partly because people are less likely to engage with screening processes, and there's complicated reasons for that, but often they don't work as well for our patients. They're difficult for people to get to, and they require higher levels of literacy than a lot of our patients might have. But also they have the risk factors for a lot of the common cancers as well, so people are maybe more likely to drink more alcohol or smoke cigarettes, and so also are more at risk of cancer. So we do see it more. We also tend to see that people have fewer social supports than they might do in an area of affluence. So we can't assume that the advice that we give in an area of affluence is going to be as easy to follow as it is in an area of deprivation, and that definitely impacts on the way that we're able to practice medicine. And I mentioned literacy issues. This isn't just functional literacy about being able to read and write, and often people feel deeply ashamed of that and don't always tell us. So we have to be really alert to the fact that people can't always read and write what the information that we're texting or putting on our screens or sending out in the post, and we have to be able to sensitively inquire whether or not that is a problem for people and be more proactive in helping them. But it's also to do with health literacy and how people understand health information and how they can keep themselves healthy. It's different. We also find that often the patients that we care for have a lower confidence in being able to address their health issues and have less of a sense of control over their own health, which can also make it more challenging in many ways to be able to have a straightforward 10-minute consultation where you zoom through everything and everybody feels fine and it's a transaction and both people go out the door feeling like it's all sorted, because it often doesn't feel that way. It's much more complicated than that. And what we tend to see in areas of deprivation as well is that our appointments on average are shorter and we deal with more problems in each consultation. And a lot of that is just because it's more complicated, but it's also because our consultation rates are higher in deprived areas as well. So it can feel like quite a tricky place to work, but a very rewarding place to work as well. And I wouldn't choose to work anywhere else other than in a deep end practice now, having worked in areas of inequality for the last 10 years. Now, we all know in this room that being poor is a well-established fundamental cause of health inequity or health inequality. And often when I'm sitting in my consulting room with my patients, I feel, actually, just what you need is more money. You need more money, you need more choice, you need more ability to do all the things that I can do, that I'm lucky to be able to do, that we're trying to circumvent by other options, but not money. So sometimes it feels like the most simple thing to do would be to prescribe money. And so many of the projects that have looked at having welfare advisors and practices to try and boost the level of income that patients are getting through being able to claim the benefits that they're entitled to are hugely important in deep end practices. So I've been interested, particularly in this role as the chair of the Royal College of GPs in Scotland, about what role all doctors can play in trying to raise health inequalities up the political agenda. And I've had no kind of embarrassment about saying that one of my priorities in my 3 years as chair is to get it talked about much, much more within Scottish Government and within discussions within the BMA. So I think that all doctors have a responsibility to use the democratic process and vote wisely. I think that we need to call it out when we hear marginalised groups being stigmatised. I don't know if we do that enough. And I think we all need to think about what our spheres of influence are, and they will be different for different people working within the NHS, but we all have some ways of influencing the system, whether it's at a practice level or an individual doctor-patient level, or whether we're involved at health board or trust level, or whether we are lucky to have national roles, which mean you can have more influence. But I think thinking about where we can influence and remembering actually that we might feel disempowered and overwhelmed and stressed and overworked as GPs, and often we are, but we have a powerful political voice, and often our patients have no political voice, so we have a responsibility to think about how we can use it, and when we do, it can feel incredibly rewarding. And I'll come on to that later, because I think that the role of doctors to be acting more as patient advocates feels like something I would love to see us doing more and aspiring to more, and having systems that enable us to do that more. I love this quote by Virkov, and I won't read it all out, but I think that the last sentence to me is particularly important, that physicians are the natural attorneys of the poor, and social problems fall to a large extent within their jurisdiction. I think that is a fantastic quote. I think it should be said on day one at medical school and then regularly thereafter. Said another way, this is a quote from Graham Watt, who many of you will know was the chair of the Deep End Project in Scotland for many years. Practitioners are not only scientists, but also responsible citizens, and if they did not raise their voice, then who else should? So it's just that sense of it's more than just delivering medical interventions within a consulting room. It's about thinking, what could we do to make the NHS better, to make our policies better? Last June, so 2019 in Scotland, we did a big campaign around the changing landscape of general practice, which is changing, of course, across the whole country, and it's different in different parts of the UK now. It feels very different in England to it does in Scotland, Northern Ireland and Wales. But we did this campaign called From the Front Line, where we were really trying to understand what is going on in frontline general practice. And we decided to dedicate a whole chapter on the role of the GP in mitigating the effects of health inequality, which is in chapter 6. So if any of you feel so moved, if you're having trouble sleeping, you can click on this link when you get the slides, and you can read the chapter. The chapter takes 20 minutes, it's quite short, but I think it's a really good summary of some of the practical things that we can do to try and improve our role within this. And I think that there are lots of things about being a GP and working out in communities, particularly in deprived communities, that allow us to have this role where we can mitigate against the effects of health inequalities. And I'm just going to briefly go through each of these areas, thinking about what does that mean and how can we do it in a practical way. So population coverage. 90% of all NHS consultations, 90% happen in primary care. So that's pretty big. And we see more than 80% of all patients on our practice list over any year. And in areas of deprivation, that's even higher. So that is a huge population coverage, which gives us huge opportunities for opportunistic intervention, health promotion, and prevention of disease. Consultation rates in deprived areas, as I mentioned earlier on, are even higher than that. So I think that it's important to think about how do we maximise the face time that we have with many of our patients over a year to make sure that we're able to do opportunistic healthcare in the best way that we can. I know it's challenging, and I'll come on to how we enable that later. We work out in our communities, so in many ways that gives us a really unique perspective of what it means to be living in a particular community and understand the context of what's happening for people within their families and within their communities. And I think it feels particularly important for people who have lots of health conditions, often coexisting mental health conditions and social issues as well, that we're able to offer this kind of whole person generalist approach that isn't a specialist approach. That feels really important because we need to be able to think about not just what are the medical needs, but what are the social needs, what are the psychological needs of the people coming in to see us, and how does that fit within their families, within their communities. And being able to know this allows us to have a much more tailored approach to understanding what it is that matters to people and what it is that they want to prioritise and focus on, which may not necessarily be what the guidelines say. And we have to be able to be flexible and adaptable to that. So the multimorbidity issue is really significant in areas of deprivation. So multimorbidity is the presence of 2 or more long-term conditions. And what we see working in deep end practices in deprived areas is that people are sicker for longer and they die younger. And that's not okay. So people tend to get sicker 10 to 15 years earlier than they would in a more affluent area, and they are more likely to have coexisting mental ill health alongside physical health problems as well. In the area that I care for in Craigmillar, there are significant parts of the practice area where the average male life expectancy is 58 years old. If you travel in your car across Edinburgh for 20 minutes, the life expectancy is 25 years longer in the same city. So this is really significant. Continuity of care. Now, we value continuity of care a lot as GPs. It makes our jobs feel much more rewarding, but there are also many patients who value continuity of care as well. So seeing the same clinician for the same problem or for different problems, but over many years, building relationships of trust feels really important to lots of patients, but particularly patients who are frail or elderly or who have complex social issues or long-term conditions that tend to get sick often. And continuity of care is important because it allows us to understand what people's challenges are that are going on in the background, because we get to know people often over many, many consultations over many, many years. And it does allow people to feel confident about disclosing things earlier if they know somebody, if they've got a relationship of trust with somebody. And it allows us also to tailor decision making to what really matters to the person based on our knowledge of that person. So it doesn't feel like continuity is just quite a nice thing to do. There's actually a growing evidence base that continuity of care not only reduces morbidity, but it also saves lives. People are less likely to die if they are seeing the same clinician for the same problem. So it feels really important that our systems are enabled to allow that continuity wherever we can achieve it. And a big part of what we do as GPs, particularly at the moment, we've had lots and lots of discussions in Scotland as in everywhere else about coronavirus and trying to bring in all the information from all the different systems and think about strategies of how we manage it. But often that is the role of the GP. We're kind of like a hub in the middle of lots of different complicated systems. So we get information coming in from secondary care, from social care, from housing, from criminal justice, from the Department of Work and Pensions. And we often act as this kind of conduit of lots of complicated information coming in. And it can be incredibly difficult for us to get our heads around it, far less people who maybe have poorer literacy and less confidence about how they navigate these incredibly complicated systems that were not designed for people who have these needs. They were designed by healthy people to be able to use them easily. And I think we probably all have found ourselves that we've struggled to navigate these complex systems if we've become unwell or had to make phone calls and sit in a queue for 20 minutes. These are not easy systems to navigate. They don't speak well to each other. And so a lot of the roles of GPs is trying to act as a conduit for information gathering. And it feels really important also when there's poor social support, because often there's no one else doing this. No one else that's pulling the information together or making sure that, for example, if someone has had an appointment up at the hospital, that they've understood what's been said. and that they know what's going to happen. So it feels like a lot of our job is about translating information that is coming in and trying to make it more accessible for people and pull it all together. And you mentioned the kind of canary in the mine analogy, Victor, as well. I think I often feel like, because we're out on the front line, that we feel like the canary in the mine for the NHS often. So if patients come in and they mention something informally to us about something that's happened to them that doesn't sound good, it doesn't sound okay, they maybe don't have the confidence to raise that as an issue, but we should, and find ways to do that. And it's not always easy to do that, particularly in a system that feels a bit overwhelmed at the moment, but we often are canaries in the mine, and I often hear things and I think, that shouldn't be happening, that's not okay, let me look into that for you. Thinking about the advocacy role, I increasingly again think that this is a hugely sort of under-recognised part of what we can do as clinicians in the NHS, and particularly as GPs. And when you get involved in advocacy work on behalf of patients, it feels like actually one of the most rewarding parts of the job that I do as a GP. And I think in many ways, when you feel like you're fighting someone else's corner, particularly when they don't have the political voice that we often do, it could actually kind of reinvigorate your sense of why you're working for the NHS and reduce burnout in an ironic way. It can make you feel like you're doing something for the greater good. And I think that we can all advocate at different levels. As I was saying earlier, we can advocate on behalf of individuals, at the canary in the mine stuff. We can advocate on behalf of communities. And the cutting down at the bottom, on the bottom right, was just an example of some advocacy work that we got involved in the practice, where we heard that one of our hugely valued third sector organisations was closing because their funding had been reduced. And this is an organisation that had been in Craigmillar for 20 years. Talk about continuity of care. They had huge trust within the community, and they offered all sorts of vital services around helping with literacy, helping with volunteering, helping with benefits appeals, doing a bit of coaching and mentoring, huge amounts of valuable work, and that they were going to close. And so when we heard this, we kind of worked alongside our patients to get a petition up and running, to write a template letter for our local MSP that we had in the waiting room that people could sign, and then we would post off. We got a question raised in Parliament. We got our local MSP to come along to the practice and meet with us, along with the manager of this third sector organisation. And it felt like a really valuable thing to be able to do. And, you know, in terms of kind of gaining the trust of our patients as well, working alongside our patients, it felt really valuable. And also it kind of reinforced that sense of working together with third sector organisations, which I think often feel like they don't have the voice that they do because, you know, they are often underrepresented or forgotten about, and yet we couldn't manage without them. So the advocacy role is on behalf of colleagues as well. So I think having a system that feels inclusive rather than exclusive is also really important. Of course, one of the kind of features of general practice is that once you register with a practice, assuming you don't move out of the practice area, you could be there for life. It's a lifelong relationship that we're aiming for. But it can often feel difficult for patients in deep end areas to use the systems that we've set up for them, if you like, for lots of different reasons. Some of these can be practical reasons. It's often difficult to get through on the phone at 8 o'clock in the morning for everybody, but often particularly for our patients. It can be difficult to travel to appointments. It can be difficult to get time off from difficult working conditions, to get away for appointments. And also it can feel difficult, I think, emotionally sometimes for patients to be able to come in and see us and accept the care that we are offering, because often their experience of care has been not a good one in their childhood, as I'm sure many of you know. And so when we are, as caregivers, trying to offer advice or prescribe a medication or make a shared decision, it can often feel like the dynamics in the consultation can be quite difficult to understand. And sometimes that is because the experience of someone trying to give care has not always been a positive one. And I don't think that we have adequate training or support around that as doctors, and being able to understand it and being able to work with it and develop our skills around that. But there's all sorts of reasons why engagement, and engagement is not a nice word, can be difficult in the systems that we have. And what we often see with our patients is that they are excluded from specialist services, which feels really awful. So it's a double whammy. Not only are you sicker for longer and die younger, but the specialists won't see you now. And there are some services that are particularly disappointing in this regard, in that they will have a policy where if you don't turn up for one appointment, you're discharged from the service and you have to be re-referred and put back on extensive waiting lists. That doesn't serve anyone well. It doesn't serve anyone well, so we also need to be lobbying for that to change. And we don't discharge from general practice. Of course, we have, some policies whereby, and this feels a bit difficult sometimes, whereby if people recurrently don't turn up to appointments, that we have to send letters to say, we notice you've not come, could we have a chat about it? And a lot of practices will have a policy whereby if you've not come in for 3 lots of appointments with no explanation, that you're removed from the list. I think that probably happens less in deep end practices in recognition of the fact that people are vulnerable, and there are often reasons for that, but it can feel difficult as well. So how do we achieve this? Because it all sounds quite aspirational in terms of what general practice can do. And if there are any GPs in the room, I don't know if there are, but many of you will be thinking, yeah, that sounds great, but how do we get there? Because it feels like often we are kind of running to stand still in general practice at the moment, particularly at the moment, has to be said. Well, we need to build the capacity of the primary care workforce, and also particularly of the GP workforce, and that's one of the main functions of the Royal College of GPs, is to try and help policymakers understand what the role of general practice is, and to value it and to fund it more, so that we can genuinely care for more people out in the community. And we then need to be able to target the resource to where it's needed, which was very well articulated in the recent Marmot report, and we need to build on the evidence base of what we know works in areas of deprivation, which you'll be hearing about later on today. But we also need to be able to create systems within general practice that support this relationship-based care that I'm referring to. So many of you will be familiar with this slide. It's quite a well-known slide, but if we want to avoid this worsening inequity in health, the NHS has to be at its best where it's needed the most. And that is still not the case. And what we are seeing often is the far right side of the slide still. We're moving further and further away from what the NHS was designed to deliver in 1948 when it was first established. Talking about the evidence base, many of these things are going to be covered, I think, in yesterday and today, but there are lots of examples of good projects that have shown an improvement for patients if particular models of care are adapted. But often these will require additional resource and additional time and headspace to get them up and running. They don't happen overnight. So we need to be able to argue, this is the evidence that shows improved outcomes for patients, and this is what we need to be seeing in general practice. So what do I mean when I'm talking about enabling relational care? It's a bit jargony, isn't it really? But thinking about what we mean by that, and how do we create systems that are the very best that they can be in terms of creating healthy relationships that allow continuity and allow trust. Now, this concept I hadn't heard of until last year, but many of you may know a GP called Dr. Austin O'Carroll from Dublin, who is fantastic. And if you ever get a chance to hear him speak, I would highly recommend it. But he runs a training scheme in Dublin for deprivation health, a GP training scheme, and it's oversubscribed now, it's so popular. And he talks about the concept of high fidelity, low threshold services. And when you break that down into terms of what does that mean? Well, a high fidelity service means a faithful service. So a service that offers continuity of care and is in it for the long run. So how do we enable services that do that? And how do we also have services that are low threshold, so they're easy to access and it's easy for people to get the care that they need? So I think this is a really succinct way of saying this is what we're looking for, because if we have services like this, then we are meeting the needs of the people who need the NHS the most. And just thinking about whether we do that or not in general practice, I think in the specialist services, there is possibly more of that because there are more often co-located services and additional funding to do that. But when people move from specialist homeless practices out into mainstream practices, it's really difficult. And I hadn't realised quite how difficult it was from both sides. So when I was a GP in the homeless practice, I would often be really frustrated at how difficult it was for people to register mainstream when they were ready to go on and register. But there are a number of challenges, I think, for patients when they're trying to register with a mainstream GP, say mainstream. Don't know if I'm mainstream, but registration processes are hugely complicated, and they really don't need to be. Appointment systems are probably more complicated than they have to be. I talked about the phoning 8 o'clock in the morning, and if you get in early enough, you get an appointment. And the appointments are really short. Are our appointment systems fit for purpose? I know that we have significant capacity issues, so we probably can't do much more than we're doing, but we should be asking for more. Our appointments are generally shorter than they are in specialist services. The mainstream practices are more likely to have these DNA policies of kind of 1, 2, 3, and if we don't have a good reason, then we have to remove you from the list. And they're far less likely to be co-located with other really useful colleagues like housing and social work, because that's just not the way it's been designed over the years. And there are far fewer opportunities for practitioner support, if any, I have to say. So, how do we start to look at what good would look like? This is a card that was released in Scotland last year, and I know there are similar cards down in England, but this gives real clarity to patients that are trying to register with practices about what their rights are to be able to register with a practice. And if you look at it, when I register at a GP practice, I don't need a fixed address, my immigration status doesn't matter, and I don't need ID. So why are we making it so hard? I don't think that is widely known, actually, in all honesty. I don't think that that is widely known by practices. I don't think that the advice on government websites is clear enough. It feels a little bit deliberately grey. So having something like this feels hugely useful for patients and also for practices. And when, for example, our patients are moving on into another area, because often our patients are more transient and they do move more, we can give them this card so that when they go to register with the next practice, it's easier for them, because at the moment it's unnecessarily burdensome. Just thinking about practitioner support, this is something I feel really passionate about, because I think we recognise there is evidence to show that the burnout rate in GPs working in areas of higher deprivation is higher, for all the reasons that we've talked about. And we're not good as a profession on the whole, at recognising the emotional labour of the jobs that we do, particularly when we're working in more deprived areas, and the effect that that can have on the ability to retain compassion in our practice. And I talk about this a little bit on a podcast, which is available on Spotify or other reputable arenas, if you wanted to listen a little bit more about this. But I think this is really important, because we don't do this well at all. And I want to just talk a little bit about an analogy that a friend and a colleague of mine, Dr. Adam Burley, is a clinical psychologist who worked at the homeless practice with me for 5 years, and I learned a huge amount from. The analogy is that if you were going to start working in a job that was recognised as having high physical labour, so if you're going to work on a building site, you're not allowed onto the building site unless you follow certain rules. Safety rules. So you have to wear your hard hat, you have to wear your digger boots, you have to wear your high-vis waistcoat. Otherwise, you're just not allowed in. If you're about to engage in a job that has a high element of emotional labour, and we all know it to be true, we just don't really talk about it very much, we have no rules, we have no safety net, and we go in regularly and put ourselves in the face of this invisible psychological masonry that is flying around, and damaging people, because we have no way of understanding what is it that's going on in this consultation that feels so difficult. What is it that we can do to help practitioners understand that there are very complicated factors that mean that the caregiving relationship is not a straightforward one often. When you're looking after people who have had very difficult and often dysfunctional experiences with care, when you're trying to offer care, it can be rejected, it can feel sabotaged. It's no one's fault, it's just what's happening. And if you don't understand that that's what's happening, you can end up just feeling frustrated or hopeless or unmotivated or demoralised or depressed or burnt out if there's no way of understanding what is going on there. So it feels really important that we recognise this, particularly for practitioners working in areas of high deprivation, and that we protect and support people in the roles that they are doing in terms of the emotional labour. So we've been interested within the Royal College of GPs in thinking about how can we teach medical students to be more aware of this? How can we train GPs to be more aware of what the skills are required in terms of working in areas of deprivation, because they are different to working in other settings, and what are the ongoing needs for people when they're already working in areas of deprivation, and also crucially the importance of having safe spaces where you can reflect on your clinical practice. And I was lucky enough to be involved in a reflective practice group for 5 years when I was at the homeless practice, and I can honestly say it felt quite life-saving at times, because you would take stuff there that you just didn't really know how to synthesise because we've never really been taught it at medical school. You would unpick it, you would think, okay, I understand that, I can sit with it and I can go back in and keep being compassionate around it, and that feels so important. I just want to leave you with this slide here, which is another quote from Graham Watt, that the NHS has been insufficiently imagined as an agent of social justice. Again, I think this is a fantastic quote. And I think if we're thinking back to what the NHS was designed to do when it was set up in 1948, we need to be thinking about whether or not the NHS is truly at its best where it's needed most. And if it's not, I think it would be fantastic if we can all come away from this conference with a sense of bravery and peer support around calling that out. Thank you very much.